Hi and welcome back to another video of Medic Notes. This video is on scaphoid fracture. The scaphoid is boat-shaped bone and is the most common carpus to be fractured. Scaphoid fractures are most common in men aged 20 to 30 years, and are high-energy injuries. Mostly due to falling on an outstretched hand. This picture shows the small bones in the hand. This red color is the scaphoid bone. Near the thumb, it is important to appreciate the blood supply to the scaphoid, which is by branches of the radial artery. The dorsal branch of the radial artery, which supplies 80% of the blood, enters in the distal pole, and travels in a retrograde fashion towards the proximal pole. Consequently, fractures can compromise the blood supply, leading to avascular necrosis and subsequent degenerative wrist disease. The more proximal the scaphoid fracture, the higher the risk of AVN. For clinical features, patients will complain of sudden onset wrist pain and bruising may be present. There is tenderness in the floor of the anatomical snuff box, pain on palpating the scaphoid tubercle, and pain on telescoping of the thumb. For investigations, for suspected cases of scaphoid fracture, initial plane radiographs should be taken. A scaphoid series should be requested, including anteroposterior, lateral, and oblique views. Scaphoid fractures are not always detected by initial radiographs, especially undisplaced fractures, if there remains sufficient clinical suspicion. Despite negative initial imaging, the patient should have the wrist immobilized in a thumb splint, and repeat plane radiographs in 10 to 14 days for further evaluation. If repeat radiographic imaging is negative, however, clinical findings are still in keeping with a scaphoid fracture, an MRI scan of the wrist is indicated. These are some pictures. Picture A shows an initial AP radiograph showing a subtle linear lucency within the scaphoid. After 12 days, another X-ray was taken, shown in picture B, where there is a more pronounced lucency observed. For management, the treatment of scaphoid fractures is determined by location of the fracture and degree of the fracture. Undisplaced fractures can typically be managed with strict immobilization in a plaster with a thumb spica splint. However, undisplaced fractures of the proximal pole have a high risk of AVN. On the other hand, all displaced fractures should be fixed operatively. The most common operative technique is using a percutaneous variable pitched screw, which can be placed across the fracture site to compress it. Some complications might occur, like avascular necrosis and non-union of the fractured bone, due to poor blood supply. That's all for this video. Thank you.